And we get the opportunity to do a male now because we wanted to show you the difference in a male or a female, especially what we're talking about. When we spoke to Jeff, who volunteered very nicely for this, he said his major concern was the area of the tear trough coming down into nasojugal groove and into the cheek over here. Okay? So we'll do that on him. I also thought that it would be nice to show how we could masculinize a little bit of the jawline area over here. Do you see that? You can't see this? Oh, you can see. Guys, can we get this up on the screen?
Let's do a little close up there, maybe.
Yeah, let's bring it in from here to here if you can.
And maybe just sit right up for a minute, Jeff, there. Just sit right up a minute there.
That's it. Okay. When you see the gonial angle disappear like this, when you get a blending, what my daughter calls the cheek neck, when you get a blending of the cheek into the neck like this, there's only one thing that can do that.
Parotid. Tail of the parotid.
Tail of the parotid. And it will come around like this. So he has a little bit of parotid tail over here that's causing that little. It's a small one. It's not bad. But I bet you we can coat over the top of it and give the impression that he's been working out in the gym like Rand all day long. There you go. Okay? So that's something that we can consider on him, and this is something that we can do on him. We also might consider, if he's up for it, and it's, it's whatever he likes, we can actually give him a little more of chin projection here in the front and maintain, this is a cute little trick, maintain the nice little cleft that he has over here. We can create that even on some patients, and I'll show you how I do that. Okay? By advancing his chin just so that it comes to touch. In men, it should touch this line, the Steiner's line over here. It should touch that line or be slightly ahead of it. In women, it should touch that line or be slightly below it. Okay? So you can see that he's offset a little bit over there. And I think we'll call it quits at that and then move on to somebody else. Are you good with that?
Sure.
Okay. So let's talk about the cheek. I'll show you the markings that I do, and then Kent's going to comment on it. Do we have a marking pen? We have a black one. How about a white one? Because they're usually...
There is a white one there. There was.
There was a white one. There was a white one. Okay, here we go. In the female...
This is a better pencil here.
That's a better pencil?
Yeah.
Can I have the better pencil?
Oh, yeah.
In the female, we said lateral canthus to oral commissure is the line for the delineation, which we call Hinderer's line, because Hinderer was a plastic surgeon who said if you're putting a cheek implant in on a patient, don't put it any closer to the nose than that, or you're going to make them look like Cirque du Soleil. That's not the way he said it, but that's probably what he meant. In a male, it's from the outside of the iris. So it's a more vertical line like this to find the inside of the cheek mound. In a female, I should use maybe a different color for that. We have colored pens right over there. Sure. Yeah. Give me the green one. Okay. So this is a female line. And that's a male line. A female line is mid-tragus to the corner of the commissure. A male is bottom of the tragal notch to the corner of the commissure. So we've opened up that malar mound so it's wider, broader, and flatter. And in all patients, we don't want it up in the temple. So his malar mound, as you can see, ideally for him is going to be this. It's a broader, wider thing that is not as angled this way, but a little bit broader and flatter in a male. The question is, where's the apex? You can find the apex by using your caliper, or you can find the apex by drawing from the base of the nose to the bottom of the tragus as you come across over here, and taking the inside instead of the middle point.
Inside of the orbital rim.
Rim, thank you. Sometimes there's a little minor stroke that happened over there, a little... Words weren't coming.
Let's keep that brown pen out here, guys.
Okay, so if we take a look now and we see, is he really going to be fied like this? Sorry, I'm going to measure in between your eyes here, okay? Thank you. Trying to guess a little bit over here. But there it is.
Yeah.
Okay? In a female, it's on that arc, but up over here. So we wanted to feminize him. We would bring that apex up over here and give him a nice feminine look. Do you want me to do that on him? I can do that on him if you like. I better not, because you're injecting your wife tomorrow, I think you said. That's right. So this is what it is. So let me talk very quickly. Kent, do you want to comment at all about that?
Good. Very
okay.
Good.
So
I would maybe cheat a little bit and go a little bit more medial for his apex.
Over here, you mean?
Yeah, I would go.
Actually, You're right, because the way I drew it, it's a little angled.
Just the way it's laying
there. It should be
a little off.
There we go.
There.
Okay.
Sorry.
Perfect. No, it makes a difference. Those little bits make a difference. We're going to see in a minute, because that's where the light is going to bounce off his cheek. So, here's the story. We take a look at a face. Can I have an orange one? I guess that'll work. And what I do with mid-face, the way I look at it, is I look at the patient. I'm going to hold his head up. Just stay on him. They don't want to see me. It's okay, guys. You can just focus on him, but I appreciate it. Bring it in a little bit closer. We'll concentrate. That's perfect. I'm going to angle him a little bit like this. Okay. When I see what he's missing, or what I'd like to fill, is this area right here. Okay?
Yeah, bingo. Exactly.
All right?
Then you're economizing on product for maximum result.
Correct. I mark the outside of the iris. There's nothing wrong with taking a pencil, guys, when you're doing your injections. That's what I look at it. I mark on patients. It gives them the understanding that you have a plan. We do this when we do tummy tucks. We do this when we do breast augmentations. You can do this when you're doing your face. They don't see what you're doing. If you have a plan on the forehead and you're not exactly sure what to do, just do something like this. And they think that you're planning something out. Okay, I just drew an exo on your forehead. You thought I did, right? Okay. Can I have a cleanser, please? We'll take that off. It's getting to be in the afternoon a little punchy, but okay, here we go. Let me just have a dry sponge, please. Okay. So I'm going to erase all these marks because you guys are going to be able to tell me what I want to do. I'm going to leave the area that I want to
here.
Reflate. Thank you. Thank you. Well, that's
we
nice.
started this reflation concept because volumizing implies volume. Because when any patient has fillers, they think they're going to look fat and full. So that's why we're kind of downplaying volumizing as opposed to reflation. We realize patients lose volume, but it's much more accurate to talk about reflation and projection rather than volumizing the face. So volumizing, I'd suggest you erase from your vocabulary. If you look, we've actually taken out a Funken-Wagnall. It's gone. So just...
I'm going to show them this. We'll start off with that filler, and I want a 3 cc syringe if you have one. I have my kit over here. Kent and I don't fish, but I have a tackle box like Kent does. And that tackle box I take with me when I'm sort of doing my injections because you always... Can we bring that chair closer? Maybe I'll use it for my tackle box over here. That's a heavy chair. So I'm going to show you the blending technique because people ask me about that. By the way, the D word is only for depth. We don't use that dilute word anywhere. Forget the volumizing word, forget the dilute word, because if you say dilute in front of your patient, you're up the wrong type of creek without a paddle.
Again. Good.
We're not diluting the product. We're blending in anesthetic to make it more comfortable. That's what my patients say. What is your nurse doing? I said, she's adding in some anesthetic to make it more comfortable. Thank you, doctor. But if I say, can you dilute up some Voluma? Can you dilute up some Restylif? Can you dilute up some Belotero? Are you wetting down my product?
Same thing with Botox neuromodulator. We teach our staff the same thing. If you're using, we usually use 5 units per 0.1 cc, but we also use 2 units. We use a mesomix of 0.5 units.
Oh, cool.
So we just tell our patients, or tell our physicians, tell our nurses that we're blending the product. So that's rather than, it takes them a long time to get away from the word diluting, because diluting sounds like you're diluting it.
Okay.
So a unit is a unit. It doesn't matter if it's 0.5 units or 1 unit or 5 units, a unit.
You're getting a first-hand view right up close. I hope you're not presbyopic. Okay, here we go. Here's 1 cc of product. In this case, I chose Voluma. Next patient will use Restylif. I use them all. Okay. So I have this product over here. I have it connected to a little 1-to-1. It's called the Luer-Lock to Luer-Talk female adapter. I'm going to prime it by gently pushing forward until I see a little bit of product bulge out of the tip. You see that? And then I'm going to connect it to a 3 cc syringe. All these syringes come, by the way, with a little bit of air at the bottom, so push that little bit of air out. Otherwise, the plunger, the black plunger, will stick to the bottom, and then when you pull it back, if you were to get it like that, you'll lose the little black thing at the bottom. So they automatically leave about 0.2 cc's of air. So you push that out. And now I'm pushing my product into the 1 cc syringe. You see that? And I hold on to this syringe. I love these syringes because I'm going to refill it. So let's keep this okay. What they have done now is they've taken another 3 cc syringe and they've loaded it with 1 cc of lidocaine, most of it lidocaine 1% without, and a teeny tiny little bit of lidocaine with epinephrine because I want just a small amount of epi. If you blend too much epi into the product, it destroys the BDDE bonds and will destroy the longevity of the product. We now connect. Okay? And I have, for example, a 1-to-1 blend if I wanted to go 1-to-1 on this. We have Volift, which is another type of product that's in between, so we don't do this as often, but sometimes we do. I'm going to add another cc of Voluma in over here. Can I have a second one, please? So I'm going to make a 2-to-1 blend. Okay? Thank you very much. I'm going to make sure that I get as much of the air out, but to be honest with you, having air in there is no big issue.
And don't use 1 cc syringes. Use 3 is ideal. 5's too big, 10's too big, but 1's too small. So the 3 cc is ideal.
So here I go. I'm pushing forward the 2nd cc. We're going to hold on to this. Good. And now I'm connecting up my 1 cc of, so I have 1 cc of Lido, a little bit has epinephrine, I have 2 cc's of product, and now we start the back and forth.
You're making champagne here.
That's what it's called, champagne. Like small amount, like 0.2. I'm not exactly, don't ever see me in the kitchen because it's never a pinch.
Chef.
It's this, it's that. It's whatever you feel comfortable with, but I just want a teeny little bit of epinephrine to cause some vasoconstriction, but not to make the block last for 4 hours like a dentist, and not to give him any blanching that he's going to walk out with white skin, which will make me nervous, although it blanches differently than it does with vascular compression or vascular injury.
And the question always comes up, how much do you mix?
Yeah, so what do you do?
I don't. My nurses do it.
Yeah, my nurse does it 20 times. She goes back and forth.
About 20 times.
Yeah.
And they're constantly making these up and making up the minis. And I have 5 nurses, and they're just go full out with making these up.
Can I have a black pencil, please? And then what I do, I'm giving you all the little things that I do. If you think it works, do it. If you don't, toss it. That's cool. My nurse will do this because she does all the blending too. And we put a little V over here to tell us what the product was used over there. And this stays sterile on our tray for the entire day. Just about. And I use this one over and over again, right?
Yeah. Yeah.
There's no reason to do that. Okay. So now we have 3 cc's of blended product, which we call champagne because it has sometimes teeny little bubbles, but this one didn't bubble up much. Okay. I take back the initial syringes that I gave you that were empty with that little connector again. Just the connector, please. Here we go. Yeah, that's fine. Okay. Make sure it's primed again.
Do you want some minis made up while we're...
Yeah, that would be great.
I'll have to get some. You don't have
Okay,
any
and you'll see how Kent does the minis. And then I fill it
twos?
to 0.75.
Have you guys made up these before?
Why 0.75?
I'll try it, yeah.
Because I'm going to get 4 syringes for the 3 cc's. I don't tell patients how many syringes I'm using. How many syringes are you going to use, Dr. Swift? Whatever it takes. I have in mind that I'm using 2, but my 2 have now become 4. They're sitting on the tray over here, and I approach the patient. She sees 4 syringes, but I told her the cost is going to be $900, but it's only 200. There's really only 2 cc's that's going in. So the questions come. The question comes and says, aren't you taking away from the longevity of the product because part of it is liquid? It's what the product wants. So what I did was I did a bunch of hemi faces. We can get away with murder in Canada. We can do things on patients that you guys can't even consider. And when the product originally came out in 2008, for example, when this product came out in 2008, I did half a face with regular, and I did half a face with this 1-to-2 blend. And it was hard for me to see which side didn't last as long as the other side. There was maybe a difference of a couple of months. But if you're talking 18 months versus 16, there's not a whole lot of difference there. And you're getting the patient the result for an economical thing. So I tell patients I expect the result should last somewhere between a year to a year and a half. Okay? So, The other thing that you're doing is you're softening the product a little bit, and its lift potential will be a little bit decreased. The G prime that we talked about before, the stiffness, but there still is cohesivity there. How much is it decrease? This product will work for me, whether it's this or whether it's lift or like I said, you're going to get Belotera volume or Teozial deep or whatever you guys have. This product will work well in 95% of my patient population. But the patients who have a lot thicker skin, he's pretty thick, but I bet you'd still work on him. The ones where I really want to project an area that's pretty tight, I go pure. Males, usually I end up being closer to the pure. And in thick-skinned people who had a history of acne with a little more scarring, a little thicker product, I look at not only the platform, but I look at the envelope that I want to lift and say, do I need a robust product to be able to do that? Okay? So I'll fill this to 0.75. Can you guys do the same thing? You can take out, and then I have these 1 cc Luer-Lock syringes. How's your back? You okay?
Yeah.
You want a water or anything, let me know.
Okay.
Thanks. Okay? And now I have 4 syringes with a plunger that's not fully out. For the women in the audience, this is great because you get more control with the plunger being like this rather than being fully withdrawn if you have a smaller hand. Okay? And I'll take one of the 1 cc Luer-Locks that you have over there. Look at the little teeny bubbles. I don't know if you can appreciate it here, if you can sort of zoom in, but there you can see them. Look, champagne. Oh, and I'll say that to my nurse. She'll say, what product do you want to use? Give me the Champagne Resty. Give me the Champagne Voluma. Boy, the patient says, man, that must be like the top of the line. Yeah, it is. Moet Chandon. There we go. Perfect. I now have 4 syringes. Can I have one on a 30 gauge needle, please? Thank you. I'll take a cleanser, and I'm going to take some dry pads, please. Chlorhex is perfect. I like chlorhexidine because the smell of alcohol drives me crazy. When I was a kid, I would go for allergy shots, and every time I'd smell the doctor's office just from around the block, I'd start to cry. So alcohol to me makes me think of my injections that I got when I was a kid. So I like to use chlorhexidine. There's also a question of whether alcohol can denature your toxin when you're injecting. If you put it into the vial, it can, but we've looked at it. It doesn't make a difference in the way it does. It was originally a myth. Cleaning with alcohol and then putting your needle through it might denature your toxin. It doesn't do that. But it can cause some reactive vasodilatation, and the patient might bruise a little more. So here's what I do. And Kent will comment on this.
If you look close up here, this is the
let me show you
fairly new by Excel. It's a 1 cc Luer-Lock dose saver. So the plunger goes right up to the base of the hub of the needle. It's like those German 1 cc we use for Botox. So that's an ideal one. And it's because of the rheology of it, the lumen of it, it's very easy to inject.
I like that.
So these are nice. So we should do that one.
Yeah, let's do that one too, for sure. Okay. Taking the lateral iris as a marking point. Because I know that the infraorbital artery can come as close to the medial pupil or mid-pupil. It's mostly around the medial iris, but I know if I stay at the lateral iris and lateral, I will not touch that artery. That's my safe zone. That's my Caucasian zone. I treat lateral cheek before medial cheek. Medial cheek is the danger area, more dangerous. Medial cheek is more difficult. Sometimes just by treating the lateral cheek, we have an effect on the medial cheek, as you can see over here. Right? So I want to do things and save this for the end, if I can. So I treat lateral before medial. This is my thought process. I'm not a great injector. I'm pretty sucky as an injector. But I'm a thinking injector. But why I do what I do and what sequence I do it. Can I have the marking pen, the black, the white? Here we go. And I figured this is lateral iris. I'm going to put in 3 pillars that are going to be like this. Okay? Just to cover my zone there. I will treat the higher pillar before the lower pillar. Okay? Great. I'll treat the higher pillar before the lower pillar because when you treat the higher zone, everything in the cheek is suspension. Look, I'm starting to have effect on the lower one already. So let's get to it. Higher first, you're going to feel a small little stick. stabilize my hand. This is the way that I do it. If I can't reach him, I'll do it on my own thumb over here. I'm going to give him a little pinch as I do that, and that's it. The needle's in. I'm on bone right now. Sorry to be so graphic. I'm going to start the injection. It's a slow injection. Very, very slow. He's a naive patient, by the way. He's never had an injection, so keep breathing. Don't hold your breath on me. That's okay. I started my injection. Look how slow the plunger's moving. I release and lift the skin just a little bit, and I'm inside my original bolus, but I'm putting my second scoop of ice cream on there for my tent. Again, a small, small, small amount of product, and I release. There's two things that you're going to notice. Number one, no blood. Why? Because that little Z technique here, south of the border, is what they teach nurses and how to inject peripherally. You slide the tissue up, you inject, and when you remove your needle, the tissue slides down and tamponades over the area to prevent some bleeding from coming out. So that's number one. Number two is I've lifted the weight of the cheek up and allowed the product to come up, and then I just set the product back down, and we can erase that little circle over there. He's in a pretty decent position that if we lean him up over here, you can see that he's already got volume over here. And I've used 0.15. That's my typical amount of product. I'll now go down to my second level of injection and repeat the same thing. So it's a small little pinch. Notice when you pinch the skin, how you drive the skin up. This is a technique that Kent and I have been doing. And the reason that we do it is because it's less pain to have the skin go into the needle than the needle go into the skin. So for those of you who are Japanese and want to commit harikari, fall into your sword. Don't stab yourself. It hurts too much. That's where you hear the expression falling on your own sword. Okay? So they would, not this way. So you do it in the nose, you lift the nose up and let the nose fall down onto the needle. When I do this, I'm pushing the skin up into the needle at the same time that I'm actually putting the needle in. And it's a much less painful thing. You're okay with it?
Yep.
Beautiful. I'm going to inject again a small amount.
See, essentially what's happening is he's touching bone and injecting, and the filling starts, and he lifts the tiny bits like I do. And the filling creates the lift. So that's why it's reflation. So that
you're about a millimeter or two off bone.
Barely
off it.
You've already started the flow.
The flow's already there. I'm theoretically inside my original bolus, number one, and number two, in this zone area over here, I could be injecting superficial or deep.
You're still flowing when you pull the needle back.
Yes, I keep the constant flow going. And I'm going to give him the last injection right here, but guess what? I'm not on bone over here anymore. So where's my injection? That's right, I heard people say superficial. So watch the depth of my needle now when I inject. It's only just like a third or a half of the way under the skin. I'll lift right off the top now because I'm in subcutaneous tissue. And I'll inject a small amount of product. It's going to sting just a little bit. Go nice and slow. You're doing great. Breathe through.
That's where you would inject too. If you had a malar crease, you don't go on top bone. You go in the sub-Q and lift it all up, and it erases that malar crease that's such a...
Can I have a cleanser, please? How you doing?
Great.
You are doing great. Okay. That's the pillars that I use to give me the structural support. Can we pan out? You can see the difference in the cheeks right now. We're going to sit them up just a little bit in a second. I've used a total of 0.3 of product. And that's where it comes into economy of product here. I'm creating tent poles to project the cheek. We're not really volumizing, as Kent says. We're projecting. We happen to shrink wrap as we get older, so we're just pushing the tissues away from the cheek, and you pan out just a little bit. Why is his nasolabial fold less on that side? Okay, look into the camera if you can, straight ahead. Let's turn your head just a little bit. He's getting some nice roundness of his cheek over here. Even the tear trough area looks better. Look straight in. See the difference in the tear trough? But I haven't injected the tear trough. I've just tightened the skin slightly and put it. Now I think he still needs a little bit of volume over here. But we can certainly see that there's a tired side to the face and this. Now, is it possible that 0.3 cc's efface this nasolabial fold? Come on. I don't believe that. I think what's happening is that that product in there has caused a difference in the way that the muscles are reacting, whether it's support behind them, whether it's a crosstalk that's happening between skeletal muscles. they tell you that only smooth muscles talk to each other, like your heart. But I gotta believe there's gotta be some talking going on between these muscles. Our facial expressions trigger so many different muscles. If everything was coordinated distally from the brain over here, there would just be no way that we could talk or smile or express ourselves. There's got to be some talk going on between the muscles. Looks much more refreshed on that side, I think. You see that?
Yeah.
Yeah, you can.
Yeah.
Okay. So now what we're going to do is, you're doing well? Is I'll show you my cannula technique and then we'll show you a little bit of Kent's. Can I have a 27 gauge needle and a short 27 cannula? That's a long one, but I'll take a short.
You want a 1-inch one? 2.5?
Yeah, I have it here.
25 millimeter?
Yeah. I have it in my, yeah, that's it. Great. 27. So I like to struggle. You know, the thing I love to do when I'm demonstrating is struggle. Sorry. Because it makes you feel that, hey, this guy has the same difficulties that I have, number one. Number two is, I try not to hyper-select my patients. We love to have patients that we'll be able to demonstrate stuff on, but I got to tell you something. Kent nor I don't walk out onto the street and say, okay, you're a good candidate, come on in and I'll inject you, and you're not. We take them all when they come in. I was in Bern, Switzerland. They gave me a patient.
It's a 25 millimeter.
That guy was a guy like this. I met him 2 minutes before I was injecting him. Thick skin. Acne scarred. I asked him, are you on any medications? He says, yes, Coumadin.
Oh, doesn't want that one.
I said, why are you on Coumadin? I've had 3 pulmonary emboli in the past 6 months. This is a true story.
25 gauge.
I said, 3 pulmonary emboli in the past 6 months. Yeah, I have this clotting problem with my blood, so they keep it super thin.
27.
And the person who had arranged this CME thing or whatever was sitting there starting to shake, saying, I didn't realize, I didn't ask. Is it okay? I said, yeah, we'll inject.
Yeah,
is that a contraindication to injecting for me? The answer is no. I just adapt to it. And then I said, why is your skin so thick? You've had acne scarring? He says, yeah, and I dermal roller it every day. Okay. This was the most embarrassing time in my professional career as far as an injector. Because the venue was a movie theater. In Bern, Switzerland, a movie theater with a screen that was 30 feet high. His face was going to be the size of the side of a building. And there was no room for me in front of the screen, so I was behind the screen, pretty much in the dark, injecting without an assistant. That's why I love Bob, because he just, look at this. I'm sitting here like I'm 5-star, baby. It's fantastic.
That's good.
So I said, okay, what happened? I changed the way that I inject. I said to them, I'm going to only use things that are 30 or 27 gauge. Forget it. I'm not putting anything bigger into this face or it's going to start to bleed. That's number one. I'm going to do my little Z technique to do that. Number two, get me some ice at least so that I have compresses that I can do that. I want compresses on the side of his shoulder so I can compress as soon as I do that. I'm going to use cannula as much as I possibly can to try to prevent bruising. So here's what happened. He did amazing. One of my better results, because you slow down and you take your time. You're going to feel the small little stick. So a little pinch. I did that on him. I spun it. You wait a couple of seconds. If you just jab and release, everything collapses. You have trouble finding that little hole. I got my cannula ready. I didn't have an assistant, so I pulled it out myself, and we'll do it on him. Let's see if he has a little drop of blood. He does. Okay? I pulled it out, I put down, I went back, and for the first time in this guy's life, he didn't bleed. And I couldn't find my hole.
They could see it on the screen, though.
They could see it on the screen for sure. He had a face that looked like the surface of the moon. There was 1,000 craters, and I didn't know which crater had the hole in it. So I started to do my usual thing, which is dancing and singing and saying, you know, this is the way that I hold the syringe when I'm putting it in. I hold it and I'm waiting, and no blood's coming. I'm slapping him. I'm pinching him. There's no blood coming, and I'm hovering like this and waiting. Okay? And on the screen, it looked like the size of a manhole cover. And this was the most embarrassing time of my life, when I'm sitting there like this and talking, and people are screaming from the audience, go up, go to the left, a little to the right.
He's not going to tell you this, but it's important to go exactly the same angle as the trocar. So you go the same angle.
If I could find that hole now, but he's got a little bit of thick skin. There it is.
Yeah.
We're through. Bingo.
So same
You're
angle
good.
as the trocar. Then you can go up or down.
Yeah. So I'm going at the same angle, and I'm going to flatten out the plane here just a little bit. But you saw the way that I was holding it like a a dart. I find that's the easiest way. If you try holding the syringe, I use the same size. Kent uses a little bit of a bigger size, which is fine. That's probably the smartest thing to do, but I'm not that smart. I use the same size a lot of times, and I, struggle a little bit, but I usually change. Can I have a dry sponge, please? I usually change the angle after I come in. And you can flatten it out, or you can go like this. And if you're in the right place, these are very whippy. Is this mine?
Yeah, that's those magic needles.
I don't like those.
Yeah.
Sorry, guys. Okay, there it is. There should be no resistance, and I'm all the way up over here. And I'll start the flow of product. And I'm using a 27 gauge cannula, I assume. You can bring me my 27.
Gauge. No.
No, I have a shorter one in there. It's in the same.
That's a 25 millimeter, that one.
Yeah. Okay. It's all right. We're managing okay. I'm killing him, but he's doing really good. He's into his mantra now.
And
we're doing
it
great.
really doesn't matter whether the port is up or down in this location, so you don't have to keep track where the port is. There's some companies that will mark the direction of where the port comes out. I'm not exactly enamored by that. I don't think it makes a difference.
I agree. So what's my depth? Everybody wants to know what the depth is. You don't see the cannulum about 3 to 5 millimeters beneath the skin. If I was doing just dermal support, or what we call subdermal sheeting, I would be right underneath the dermis. But I'm in a little bit deeper. I'm coating very gently. He's doing amazingly well. And even with this product, which I won't do, if I wanted to from this position, I could flatten it out and come right up into the tear trough. But I want to show you something about tear troughs that we're going to do right now with him. How you doing? So what have I done? I've put in 3 tent poles and I've put a canopy over the top of it. I've created a tent. Patients who have very thin skin, you do those 3 little tent poles and then you make a nice canopy over. Otherwise you're going to see the bubbles of the tent poles. You make a nice little canopy over that. You support the skin. Okay? Chin up again, my friend. Can I have a wet one to just clean this up? He's looking pretty good. Right?
Yeah, very good. Excellent.
Yeah, I'm quite happy with that on this side. So, I'm going to do something before I get to the apex over here. Kent, can you do, want to backload BD2?
Yeah,
Girls, what do you have here?
They know how to do it, but I could show them let me show them on stage here again.
Nope, I want to use a little bit of Resty. Yeah.
Let me just show them on the camera here again.
Yeah.
So just a 27 gauge is fine, ½ inch.
Can you blend this 1-to-1 for me, please? You know how to do that now, huh? I spoiled you from last time. Yeah, so you're doing it, aren't you?
You want to blend for your BDs too?
Yeah, let's blend it 50-50.
Okay.
Okay? I very often have my nurse blend the stuff. You saw Kent, did you show that video? Yeah, you did show it on the first day. Your girls come in at 4 o'clock in the morning and prepare your stuff. 5.
Literally. Actually, there were more there before 5.
Let's take a look. Give me a smile now. Let's animate and make sure that you're not driving your cheek up too high. You're not. This is a light reflex. It's actually not, there it is. It's not actually a depression, but he's looking very good. Excuse me. Any questions about this at all, guys? I can use either one. I don't know whatever they pulled up, but I could use silk.
Just a comment about if we're using the Resty family, Purlane, Restylane, or Silk, do not keep them overnight in your BDs because as you know, have granules. They're a particular product.
They jam it.
So you'll jam up the 31 gauge. You can't get it out, and you can't take those needles off because they're sealed.
Correct.
So all you can mix others up and keep them for a few days.
I have my girls. That's what I was just about to say. My girls do it at the end of the day. They prepare for the next day. How long can they store for? This is heresy, guys. This is witchcraft. We don't know, but look at this. Thank you.
Got to make you look good.
Yeah, got to bring me a pizza.
The Resty family, don't make it ahead. Make it just as you're using it for the day kind of thing. Otherwise, you'll waste product because you can't get it out.
Doing a great job. You can leave it in this, actually, and put it on a 27. What do you got there?
That's still blended.
You have to blend it. Oh, I see. So she's doing a 1-to-1 blend because I like to use 50-50 on the areas around the face. Around the eyes, I mean, because I want to give it the volume that it needs. I'm going to do a little bit of tear trough work in the way that I do it, and then maybe on the other side I'll do it the way that Kent does it, purely with a cannula. Technically, it's a little trickier when you do only cannula from this angle, because you have to change the angle of the cannula to go this way. And you can leave a small bruise over there, which happens every now and then. But we're not going to let it happen today.
Or
Is that all
you
right?
go with a cannula from
Here.
to here.
That's correct. Otherwise, you make a
Nothing
you make a second point. People are asking me about the blending, that sort of witchcraft thing that I blend both filler and toxin into the same syringe. Is there any medical evidence behind it? The answer is no. Okay, I don't know what happens to the toxin. I know that when they put lidocaine into these products, the way the lidocaine worked changed. It worked much quicker. I don't know whether the toxin works quicker or not because I'm seeing effect. But think in an area where you want both products to be. So upper lip is exactly, I put the filler and the toxin separately in that area, so I'll blend them together. Crow's feet, I could blend it together and do crow's feet.
We'll just do it on
or neck.
Stage for them.
So it's here, here, and here that I do it. I heard people are trying to do it for the glabella, but it doesn't make sense because you're injecting intradermally in the glabella with the filler, and the muscle is way deeper. But here, it's dermis on muscle. Here it's dermis on muscle, and a lot of times it's dermis on muscle over here. So Kent is going to show you how we backload.
Just show you on stage here. So this is just a BD2. This is a 0.5. I'm
going to get you a 0.3.
I prefer the 0.3s, but this is a 0.5.
I got one here somewhere.
0.3?
Yeah, I brought a box of them.
Okay, good. Let's have a 0.3. I don't particularly like the 0.5s for a number of reasons.
Yeah, I like the 0.3s too. They come like this. Okay? I'm not here to promote the company, but we use them. I use these for toxin as well. Here you go, Ken.
So 0.3. So just take the tops off. Put this in your other hand here.
Keep it sterile. You notice the way he's keeping it sterile there.
And you can inject it upside down, but generally you want to use a 27 gauge, or you can use the problem with this short one.
That's perfect. That's all I need.
You just need much. But see, if you're using a longer needle,
that's right.
You can inject more. But then you just push the air out the other side, and it's as simple as that.
Right. And you usually end up with about 0.15, which is exactly what Kent has over here. He has 0.15 of a 50-50 blend of Resty. Could be Resty Silk. We use Resty here. It's the same. In his situation, I'm not worried whether it's Resty or Resty Silk because his eyelid skin is actually a male skin. It's a little thicker. If he was female, I would have definitely used Resty Silk, a little thinner product, okay?
If you want more product, just use a little longer needle.
Correct.
That's all.
As you inject, you'll see the product flow backwards. You stop it when it gets to the top. You put your needle in, and as you push it forward, all the air comes out. So, we're going to do this little tear trough area over here. We're good?
Yep.
We're going to do this little... Is that reflecting or something?
Yeah.
Okay. He's now anonymous. What happens when we should put it on his toe like a skin tag for the pathology part?
Where is it?
When they...
Oh, don't worry about it.
You're looking for the magnet? Okay. You're good. Thanks, Jeff. So here we go. He has a little bit of a crescent over here. I'm going to show you the technique that I use. Okay? I'll start backwards. I usually do lateral first. But if I'm going over here, I stretch the skin out. I look for little vessels. There's a gazillion of them. Can I have a dry sponge, please? I'm always prepared to put a little bit of pressure on the area.
He's got a minefield of vessels.
Yeah, and I'm trying to find an area in between. It's a little difficult over here, but we're going to fire it in anyways. Small little stick. I'm on bone right now. I'm putting in a small deposit, usually about 0.05. Nice and slow, watching the skin. Release, and then just a little pressure. Same thing coming across over here. Minefield again. Little stick, down on bone. Very small amount of product. And release. And I can trace that up over here. Here, I've probably put product into the muscle. I don't think I'm under the muscle at all because it's attached. Here, I'm going into SOOF. Here, I can put in a larger quantity of product, which can create a little bump, and then I can flatten it out. Okay, head up. Let's take a look and see how you're doing. No bleeding so far. We've just about wiped out that tear trough. I still want to show them, I'm going to show them the other technique anyways. You can use a 30 or a 27 gauge cannula for this. I think she gave me 30 gauge cannulas here. My girl usually does that, my little nursey.
Are there any other products you can guys?
You're getting a product called Volbella, which is great. I'll be honest with you, I do not use Ultra or Ultra Plus under here because of the fact that they're too hydrophilic. How you feeling?
That's fine.
Yeah. How about what?
Belotero.
Belotero is great. Belotero Balance is a great product to use over there. You'll get Belotero Soft, which we have, which is also a great product. I've seen people use Radiesse. Look, I think that you can use any product anywhere if you're a very good injector and you know how to wet down the products, you can do that. Michael Caine does that all the time. What's the problem? If there's one area or two areas on the face that the personality of the product is going to be revealed, it's going to be in tear trough and lips. Tear trough and lips are very unforgiving. And if you don't do the right technique, your window of safety, not safety, but of a good result is reduced. So, I can give any one of you I'll give you 20 syringes of Resty. You can do his whole face and make it beautiful by doing things like that. But we're going to try to do it according to the way that the products are designed. I mean, I'm trying to paint with a little thin brush here. Yeah.
People with Restylane still use blender?
I do. I just don't, but that's just me. You can probably use it straight up over here, but I found that my late occurrence of edema and my overfill and my Tyndall effect has been completely eradicated by doing the 50-50 blends. I'm telling you this from my practice. Again, accept or reject. If you hear me talking on the podium for a company, I won't talk about it. But in my practice, we do it all the time. I've used over here 0.15 of 50-50 blend. He has 0.7075 of filler in his tear trough. That's it. Do we have a 30 gauge? Come on, she put some in here. I know that she did. I'm going to empty everything out to find it. Here it is.
30 gauge.
Yeah. So what I need is a syringe now that has that 50-50 blend.
You don't like this syringe, huh?
Yeah, but you'll put it in a 1 cc, please. It's close, but it doesn't hurt when you stick it. It still has a little bit of a blunt tip to it, which will make it less bruising over here. So it's a good question to ask. Why do I use the 30 gauge? It's the only area I use the 30 gauge, and most of the time now I use a 27. But if you're going to start doing injections into the tear trough, the way I'm about to show you right now, I would suggest try a 30 gauge to begin with. You're saying, well, that seems more dangerous. It isn't. What I want to do is control the amount of product that's coming out. With these wetted down products, you just put a little pressure on the plunger and it flows right away. With a 30 gauge, there's more resistance. You have a little more control. Once you get used to doing the 30 gauge, switch to a 27. That's perfectly fine. I'm going to give you one little stick here, my friend, okay? You ready? Mm-hmm. Okay. So, I'm just going to load it up a little bit over here, try to find a place that maybe doesn't have... there's a syringe? Great. Okay, and I'm going to show you this. You're going to come and pull that out for me. Let me get a little... Can I get a dry sponge, please? Thank you. Nice clean one. We're going to stretch the skin, hold my cannula like... This is how I do it. I hold the cannula like a dart. Much more easy to control. Go ahead. She's going to pull out that little thing. Going to see if I can find my hole. It's somewhere about over here. We're going to wait. See, now he won't bleed, but we'll wait. All you have to do is be patient. It'll show itself. There's one down over here, but I don't think that's it. Is this it? No, I don't think so. Is it?
Talk to it a little bit.
Mm-hmm.
Come here, little hole. It'll show itself. I don't think so. I think that's one of the ones I used to perforate. You think? Let's give it a second or two here and we'll see. No, that's not it. Somewhere over here. I'm a little more medial. Okay, so anyways, I was telling them about this story.
Just make a new one.
Yeah, I will make a new one, but I'm being a little bit persistent because I just want to show you. He didn't bleed, and I like that idea. So we'll just wait a bit. Wow. Everybody says that's it. It's not. It's higher up. Here we go. A little to the left, a little to the right. Yeah. Is it that it? Yes. I think that's it. If it isn't it, I'm finding it. There we go. I just made a new one. Okay. So we're going to go back into this little hole here, and I'm going to flatten out my needle, or my cannula. And I'm gently... look, I haven't even injected. He doesn't even feel it. Look at the superficiality of where I am.
Subdermal, folks.
This is the plane that we used to do skin-only blepharoplasties on. Notice when I'm holding the plunger, if you can back out a little bit with the camera, and I'll show them how I'm holding the plunger. The plunger is now at the base of my thumb instead of at the tip of my thumb because I have more control to squeeze with the small muscles of my hand. And I'm gently going to coat back and forth over here like this. And you'll hardly see the plunger move. Okay? Am I hurting you at all?
It burns.
It burns a little bit? That's the lidocaine. That's about it.
So remember, the orbicularis oculi in that medial location is attached to bone. So that's why in the blinkers, squinters, animators, you put it in the muscle, then you can sometimes have issues.
Look straight into the camera. You're saying I could put a little more in, and I'd love to, but am I going to?
No.
Thank you. Because that product will swell a little bit and do the rest of the work. It's the most difficult thing to sit on your hands and not treat something 100%. But look at the difference in the two sides right now. How much did I use over there? Maybe 0.05 plus to 0.75. So I've used 0.125 of product for his tear trough, which was only 0.06 of actual product. And this is where I found it's made a massive difference. I don't know if you can appreciate it, but he looks even lighter on that side than he does on the other side because I've coated over the Tyndall effect of the blood vessels over there.
That's exactly how I do mine with
Yeah.
the light cannula.
And there it is. What we'll do now, if we can move on a little bit, I want to find the apex of his cheek. So can I have a pencil, please? I almost forgot about that. You're doing good? So, bottom of the nose to the tragal, bottom of the tragal notch, or the bottom of the tragus, I should say. And then the inside. Remember, Kent and I were, he's just mentioning, he liked the idea that maybe it was a little more medial, about over there. I like that too. Let me have the voluma that you have over there, the blended on a 30 gauge needle. This little area over here, we're going to inject. Give me a cleanser, please. You can ask any question you like. Not from the same injection point, but I would have used a 27 gauge cannula over here and gone over there, and I would blend in a little bit of toxin. And I would just coat this area right over here. That's what I would do on him. I'm sorry? Okay, so let me ask you. I won't give it. I'm going to ask you to figure it out. So let's think about it here for a second, okay? When I'm working around the eyes, you're going to feel a small stick. Okay? I'm probably right now in zygomaticus major, maybe a little bit. I'm going to relax just a little bit, and I'm going to come up and lift that tissue and create a small light reflex. A slow injector is a good injector. I say I'm a good injector because I'm slow. My friend Stephen Liu is deadly slow. He's an excellent injector. Okay? The slower you are, the better you are. And trust me, you can put in a syringe. You know that you can do this in 15 minutes without all the talking that I'm doing. It's talk aesthesia mostly. Okay, pan out. There's my younger boy. That looks really good. Relax. There you go. Do you like that? Yeah, I think that's better. We have to do something for the wobble down over here. But so far, what have I used? I've used, from the voluma, I've used literally about 0.3 of voluma, maybe. I don't think 0.4 of voluma, which is really 0.3 or something, because I have a blend of 1/3.
Yeah.
And I've used point something, 0.075 of. So you understand how you can do a full face with theoretically 2 syringes now? 3 syringes? And I'm telling you, the result will last. Certainly last long enough that the patients will be very satisfied of only having to come back maybe once a year. And they're not down to an empty tank, they're down maybe 1/8 of a tank, and then you don't need as much, you top it up. I'll tell you something else that I love to do. I love to keep those little BD2 syringes separate in a little box. I always indicate on them what's inside, because you might confuse them with toxin, don't want to do that. Patient comes back after having a full face, and I've told this to the group last time. This is the biggest practice builder that I have. So he'll have his face done, he'll come back and he'll say, I absolutely love the result. And I'm going to look at him, there's always some asymmetry, there should be, and I'm going to say, you know what, I love the result too, but you're a little off on one side of your cheek, I want to adjust it, no charge. And he'll look at me and say, what are you talking about? I said, I think I can make it a little bit better, let me just adjust it for you. Out comes the little BD2, it's sterile. The rest of the syringe is still there from other BD2s. I pop it in, I fix it, and I say, you're on your way now. What do you think he says when he walks out of the office? Or what she would say if she walked out of the office? I can't believe that guy. All he was interested in was the result. It costs you nothing to do that. And that will be a big practice builder for you. It really is. Okay? So even sometimes, and I hate to say it, but even sometimes when I think the result is like 99 out of 100, I don't mind putting in an extra little bit just to make it 99.2 out of 100 because it's a confidence thing with the patient.
Are you saying you have BD2s that you save, or is it one that you use on a patient?
Oh no, if I use something on a patient, if the syringe hasn't been completed for whatever reason, I find a place to put it, but then I toss it. I don't keep used syringes around. Right? I'm talking about the fact that if you have a syringe and you pull off 0.2 cc's of product, which is 50-50 blend, I fill up a bunch of those BD2s, if it's not a particulate one like he was talking about, and I run through them during the day. So a patient might end up with 1.3 cc's of fill rather than exactly a 1 cc.
At what point do you see your patients for follow-up, new patients?
I never see them again. I'm a nutcase when it comes to follow-up. Every patient who's a naive patient comes back. The first time they get injected, whether it's toxin or filler, has to come back to my practice and must be seen by me or my nurses. And then the nurse knows what to pick up on it. And then, because they're your billboards. You don't want them walking around with one brow up or with a cheek that looks a little bit missing or something. So I see them all. But once they're already experienced and they're wired for the aesthetics, they'll call my office if they see something off. Yeah. Otherwise, I let them run for 3 months or 4 months. Can I have a cleanser, please? Here we go.
I just drew his facial artery and the jaw line.
Beautiful. So I'm going to take the Voluma again that's been wetted down. It's a great product to use over here too because we're going to stick with it on him.
He's got a nice masseter there so you can feel it easy.
Yep. I'm going to take a 27 gauge needle. Yep. 27 gauge needle, and then I'm going to take it on the 27 gauge cannula, which I have the shorter ones, which are buried under here maybe. Here, you see these little guys? There it is. Perfect. It's a stiffer cannula. The other ones that are too whippy, I'm not too crazy about. How you doing? Good. Your backside's okay in your back? Because you've been sitting there. I would be crying with my backside like that. We're going to do this, and then we're going to accelerate it into the other side, okay?
What size trocar would you like?
Give me a 27 gauge trocar again.
In our Canadian meetings, Arthur does one side and I do the other side.
Right.
Right, Arthur?
That's what we do. We tag team. Sometimes we do it at the same time. The poor patient's struggling. The feet are jumping all over the place. Now we don't. Small little stick here, okay? There we go.
So what location is he in? What level? Sub-Q.
Yeah, it's got to be sub-Q. You go down deep over there, you're going to hit that thing that you don't want to avoid.
So he's going to go exactly the angle of the trocar.
Okay.
So just take that trocar out there.
There we go. Now we have a little drop of blood, but now I'm in, and now I'm flattening it out.
And he flattens his syringe needle right out so it's parallel to the jawline there.
Thank you. Good.
Now watch when he gets to the labial mandibular fold. The mandibular ligament's going to act like a speed bump.
Absolutely. And I warn patients that you're going to feel a little pop. Okay?
Right there. See it pucker?
Yeah.
Okay, that's the mandibular
ligament.
cutaneous ligament.
So my injection here is an anti and retrograde injection. Once I have a little bit of product, watch, it's going to bump again. I'm going through the ligament again.
See the ligament right there?
It's going to pop. There you go. You feel that little pop? Yeah, I'm sorry. You feel it.
It's a little annoying.
Now, there's some people who say that you have to inject into the knee of the ligament because you're going to straighten it out and you're going to lift the face. I'm not exactly agreeing on that.
I don't agree with that.
And ligaments are there to prevent the face from sliding. They say the ligaments stretch with age. I'm not exactly sure that happens either, as much as they stretch. If you've ever seen a ligament, they're pretty tough. But the thing you have to be careful about is ligaments are anatomical landmarks. And right behind that ligament, right behind it, is the marginal mandibular branch of the nerve. And if you go down too deep over there and put a little product in, he's going to have a funny smile for probably about a half an hour or so. So we're going to try to avoid that. You doing okay?
So I do exactly the same way. Antegrade, retrograde, both, and just slide it along. And we got just ultrasound gel there, ladies.
Yeah. And now the trick is to try to do it through the same port.
That's good. Excellent.
You have to practically withdraw the cannula completely, flip it around towards the other side, and then advance it this way. And that can be a little tricky sometimes. Okay? If you touch the parotid fascia over here, the patient will tell you, It's very, very sensitive. Fascia is extremely sensitive. When we do liposuction of the abdomen, if we touch the fascia on the rectus muscle, the patient will jump. So you got to be very careful here. I'm going to backhand it over here so that you can see.
Now, if you can't do the little twist here, just take your trocar and go the other way until you do 100 of these, and then you'll be able to do the twist there.
Would it be better to use a longer cannula?
You can, but it's a little more flexible. But I felt that with the distance that I had to go, his gonial angle is right here.
Yeah.
That I was okay with the shorter cannula.
You can practice.
Now you can walk around the other side of the patient stuff. I'm just doing this to keep my hands out of the way so you can see with the camera, but I'll inject with my index finger over here too, and I'll try to create that little thing. Now let's say I run out of stuff like I did over here. You're all right? Yeah. Can I have a compress again, please? What I very often do is I will unhook if I can, depending on how tight they put this on. These girls are strong. I don't think I can do it. So sometimes I even use a little clamp. I unhook and leave the cannula hanging.
That's that little lure lock with the dose saver you're going to use now.
Okay, I'm going to have to come back in because we're going to have to put the cap on to remove that.
Are you doing a real narrow fan? Is that what you're doing?
Yeah, I'm trying to create a ridge over here. You can see it developing right now. Remember? Lifted him up a bit.
Trying to create a shadow there.
Here.
It's more of a...
See the difference? He's starting to get a straight line over here.
You can see it here.
Okay? This is distracting over here, but I'll take that off if you want. So I'm just giving him a little support over here. He needs a little bit more right about over here. You can see that. But I'm starting to create the L, as we say. Here we go. Thank you.
This is that little lure lock dose saver. Because of the small lumen, the rheology is, if you've got a stiffer product, it's easier to inject.
Are you going to also do the top part of the L?
Yes, I will. On him I will because I really want to try to... There's two things that I'm trying to do on him. One is to give him the definition between the cheek. You're asking me if I'm going to do the vertical ramus of it over here? And the answer is yes. But I won't do it through this access point. I'm going to just put in a teeny little bit more over here to try to correct that little area. And this isn't volumizing. This is actually structuring the area. Can I have the needle again, please?
These will actually look better in a week than they do right away.
Okay, thank you. Let me have a cleanser, please. You're ahead of me, aren't you? Always, good. Okay. Let's see if we can get the right angle going on this one. I'm going to stretch the skin up here a bit. Put it on stretch. Go ahead. Got my eyes on it. It's somewhere over there. There it goes. And this sometimes what you may have to do actually is put a slight bend in the cannula. Because I find that going in an upward direction like this, sometimes I end up having my hand resting in women on the wrong place. So...
And when you do this bend, then you can't do the twirl. So you just stay straight. It's like when you're doing above the brow and you want to curve, then you can't be doing the twist of the chubby checker twist there. But
you'll see, I'm cantilevering by pushing my cannula against the skin, which will flip this area up. People think to go superficial, you have to lift it like this. Your cannula will dive deep. So push it the opposite way. Okay? And I'm fanning this entire area over here. Okay?
It's a little sensitive for some people on around.
Yeah, because there's a ton of little septae over here. These are the parotid septae. There we go.
Actually, we're figuring out a neat little microphone to record this sound because it sounds like bubble wrap. So you can get the idea.
I like the description that you did about going through the septae of
grapefruit sections kind of thing.
Can I have a little bit of the ultrasound gel, please?
Would you do that area with UltraPlus?
Yes.
But you're using Voluma.
I have it already loaded and I'm fine with it over here. But UltraPlus is the most cohesive for Allergan's products. That's a lot. You guys are very generous. Ultrasound Plus is the most cohesive of all the portfolio for Allergan. It's the one that will stay together the best. That's why I use it for dorsum of nose if I'm using an Allergan product. I'll use it for a tight definition over here too. But as we were talking about with Kent before, the product that I like to use a little bit more over here, Voluma is a little softer. I mean, it's higher G prime, but it's not as cohesive, so it has a little more of a rounded edge, which I don't mind over here. But you can do it with both. Probably the only difference will be in the amount that you use. Maybe Ultra Plus, if you're a really good injector and you just fine line it along over here, that probably you'll use a little less than I would have with my Voluma. But we have the advantage of not paying for the product here. He's paying for it. I'm not. No, I'm not paying.
There's a new product you'll be using called Emerville Classic. We like along there too, right, Arthur?
Yes. That's beautiful on
Nice product. Yeah, see, that's better.
That's what we want.
Yeah.
See the little angle and everything is just looking. Let's sit him up a bit and get the neck part out of the way.
Just put your chin up a little bit.
That's it. Just up a little bit.
There you
And we'll
go.
see. That's what we want.
There you go.
Okay?
Bingo.
Yeah. And you want that definition as it comes across over here. You're doing great. Really good. By the way, we're only doing one half a face.
That's what I figured. I have to come back to the next meeting.
So, yeah. What the next thing I have to show you is how to walk with your face just the right side showing.
It's okay. I'm trying out for Phantom of the Opera.
Oh, you're trying out for Phantom? You look great like this. This side.
Now,
I'm
what's
not so
interesting about that procedure with the jaw angle restoration is
I'll take the
there's
Voluma, please,
very
on
little
the
trouble
30
there,
gauge
Arthur.
I'm sorry?
I say the nice thing about this is the results are so good, and there's very little trouble to get into.
No, if you stay superficial over there, you'll stay nice and soft. So we haven't used the full syringe yet. Maybe about, I've used one full syringe of the 1-to-3 blend, so maybe about 0.7 of Voluma, and we used a little bit of Resti, which was blended too. So I would have predicted, looking at him, that he was probably a 3 syringe candidate. He would have told me he has enough money for 2. I would have thrown in the extra $200 for the third, told him it's going to cost him $1,700 or $1,500, whatever you guys charge on, or $2,000 or whatever it was. He had a budget for $1,800. I pushed him the extra 2, got the extra syringe in to give him the result, and he's going to be so good looking that his wife is going to want to get injected tomorrow. I bet she's getting injected tomorrow. I predicted it already. Yeah, he's going to inject her tomorrow, so that'll be it. In women, I have a tendency to put the injection on the gonial angle by going vertical right down onto bone and putting in a small bleb to give them that little cut over there. Okay? In men, it's a little more difficult because of the thicker skin, but you can feel it here sometimes. You see that? And I have to feel the bone. I might do it on him just to show you the difference in the technique, but we'll see. So you can ask questions, Kent. Why don't you field questions while I kind of quickly do the other side of his face and we get to the next patient?
No,
Can I have the...
you mean like Madonna implants in her chin, you mean? Cheek implants?
I'm going to show them that.
You can, because it's just, what is it? It's just plastic.
At this point.
So you can inject above it, and you're fine. Same with the chin implants. You can inject around it. I prefer to take the chin implants out because they look like crab apple.
Guys, you have to change the needle. It's a little
like them because there's no attention to the pre-gel sulcus or the chin, but yeah, you can inject around them.
Doctor?
Yeah.
He would prefer not to inject on that area because the risk of infection can happen years later.
Right.
I've injected lots of them and I never had an issue, but I certainly do small amounts. Where I've done most of the cheek implant corrections is the malar crease and festoons, where you're staying shallower and you're not on top of the implant, you're in subcutaneous tissue. Those implants are right on top periosteum. So I haven't had issues with it.
Yeah. Do you think eyes open or closed make a difference in the position of the oval front?
No.
I use topical all the time, personally. It's fiddly, it's expensive, but it's the main reason I use it is to cause vasoconstriction. So we're careful with how long we leave it on because it can make the skin a little spongy. So we use lots of them. We now use the last 3 or 4 years EMLA type product, only is double strength. It's 5% prilocaine, which causes vasoconstriction. So we used to wrap them with press and seal wrap, but that's a little fiddly, so we just put it on straight, and it works very well. But it's not necessary. It depends on your patients. Using
It's too tight. You broke it.
it's 5% xylocaine and 5%
Just take it off.
lidocaine, but it's the lidocaine that causes the vasoconstriction.
What you got to do in a situation
And the same
like that.
eutectic base.
Some of these
There's
don't
lots
go
of
on
different
to-
bases,
this is
but the
the
base
oldest
mimics
one.
the original pH of the eutectic base of amla. And
Did you get swelling that makes things harder to see?
we have a compound that makes it up, but it does cause a little bit of facial edema if you leave it on for a half hour. We leave it on. My nurses time it. They leave it on for 10 minutes, sort of max. And it does help, particularly lips. It makes a big difference because they have the lips just feel really numb. They don't feel a thing.
Can you give us your technique for injecting the submandibular gland?
Well, you can get around the parotid. You can actually feel the parotid if it's enlarged. And parotid enlargement is very, very common. And the submandibular gland, if you have the patient stick their tongue on the roof of their mouth and push their tongue back towards the hard palate, it'll project the submandibular gland down so you can actually see it easier. But you cannot get your fingers around it, right, Arthur? You can't get your fingers around the submandibular gland. So you don't, the parotid, we pick it up and inject it with a half-inch needles, I do. And the submandibular gland, you can see it easier than you can feel it. But you can't pick it up, but you can inject it.
For masseter injection, what you want to do is draw a line from the corner of the mouth to the bottom of the earlobe. We used to do it to the tragal notch, but we do it now to the bottom of the earlobe. Feel for the anterior border, draw a line for the anterior border of the masseter, and plan all your injections at least 1 centimeter behind that, because the risorius muscle takes its origin from the parotid fascia. And we don't want to touch that, or he won't be able to open his mouth when he smiles. He won't be able to brace it across. And then depending on which technique you like, I usually do a triangle with one up and two down. But you look for where the bulk of the muscle is, and the key on masseter injections is?
Depth.
Depth.
And also, I do the same 2 down and 1 up to clench your teeth a little bit. But those that have a tendency for TMJ seem to have a tail of the masseter that goes up a little higher. Okay, relax it. See, and his is actually higher than you think. So you want to go usually 2 and then 1 here.
Right.
And right half-inch needles to get the deep.
Doing great. So
would you inject Kybella in the same session?
Good question. I would.
Inject what in the same session?
Kybella. Or Belkyra, as we call it.
Yeah, I do. Yeah,
we're going to take a really quick break. We do want to make sure everyone has an opportunity to use the restroom, get some more water, coffee. So we're going to take 10 minutes. The doctors will be on stage, so if you do still want to ask them questions, feel free to come up and do that.
Jessica, why don't we just show my tear trough video before they go on break? It's only like 4 minutes.
Okay.
And then, because it's in keeping with his tear trough, exactly how we do it. So it's on screen right now. So while Arthur's finishing up here, so go ahead and play that. Improving the tear trough deformity is a common approach in aesthetic clinics. It's important to understand the anatomy, that it sits below the tear trough ligament. And 3 basic classes confined to the medial side are full and graded according to severity, length, width, and depth from grade 1 to 4. And the orbicular sulci is attached to periosteum on the medial side, but not laterally. So there's a difference in injection in medial and lateral. This patient is a former model with quite a number of challenges, including the tear trough area. And you can see from her results, she has a nice, softer, smoother infraorbital hollowing improvement, as well as the eyebrow position. Our patient today, you can see that she is 23, is now 55, and has significant facial deflation, including the whole periorbital zone, particularly the tear trough in a class 3, extending from the medial standard tear trough to the lateral orbital hollowing. Here I'm just sketching out areas that need to be reflated, contoured, and blended. But our focus for this video is improvement of the tear trough in several different techniques. Generally, I'll use 27 gauge cannula, 1 inch length. But here I'm using the 27 gauge 1.5 inches so that I can inject both the standard tear trough and the lateral orbital hollowing from the same trocar hole. It's important to inject intradermal in a subdermal location is the aim here in staying away from muscle, because in those that are very animated, then with squinting, smiling, you can have a hygroscopic product become more hygroscopic and create swelling. Here I'm subdermal and just showing in the plane where I'm at, and I'll go right to the apex, and I use a blended filler that has a low hygroscopic properties, some cohesiveness to it, but very little viscosity. You have very small amounts, very gentle. It looks like I'm being assertive here, but it's a very gentle technique. Here I'm up to the apex of the tear trough, and smooth out the edges as well, so you do not have a solid band of filler. So you want to gently fill in this whole zone that's deflated, and then blend very carefully and mold with cool ultrasound gel. You can stay in the same trocar and go laterally. Here I'll show a different technique where I go from the lateral side on the left side and inject an opposite way I did the other side. So here I'm using the same 27 gauge cannula. Here I'm bumping into the
ligament
size and length,
orbicularis ligament.
and the orbicularis retaining ligament is a bit of an obstacle. We never notice these with needles, but we notice them with cannulas. They're a little bit like speed bumps. Gently blend this in. I have not injected her standard tear trough yet. I'll do that second. So it's just another way of doing this. You can also do this with needles as well in a vertical technique. Here is a patient I had a full facial restoration, including the medial tear trough. And you can see his excellent results with a low hygroscopic product. Okay, good. Thank you.
I want to show product. Go ahead. Take some questions there.
Go ahead. Yeah.
What was the product you injected?
What was the product? Oh, good question. That actually was Redensity 2, which is a product from Switzerland. It's very much it's a hyalocross. It's like very, you can equate it to silk. And I blend mine for the orbits 1 cc to 1/4 of cc of normal saline, and that's how I'm doing. Arthur's doing 1 to 1, Arthur.
Yeah, because
1 to 1.
Resty, which is a little more
hygroscopic.
Yeah.
So you'll get Redensity 2. It's beautiful for orbits and lips. It just has a very nice ability to blend, almost blends on its own without much molding by your hand.
Okay.
So, but silk is an excellent product. There's lots of good products for the orbits, but I think blending becomes important. So the reason we started blending, then we didn't blend, and then we're back blending. We're back
straight up
blending more the last few years because of the technique in orbits. Otherwise, you can get lumps and bumps and areas that don't stay as well. But I think the trick is to learn something you're happy with, and then not overfill it. We always try to get 75-80% filled, because we all recognize that in a few weeks you get 90% because of the hygroscopic effect.
And something else.
But the cannula technique for tear troughs is a dream to do. Very rarely they bruise. They hardly feel a thing. And it's a slick little technique. It looks like they'd feel it, but they just don't feel much at all.
One last thing before you guys take a break. If you look at him from the profile, and we can't get his head all the way over, but he has a little bit of retrognathia. His chin is a little bit back from where I would like it. He has a small little dimple over here, which I'd like not to obliterate. When I do chin augmentations or enhancements on females, I do a central injection, and I try to actually narrow the chin and lengthen it as well, sometimes vertically. But in a male, I'll use 2 points of injection. You can do the injection technique like that, same way that I usually do it in women, but when I'm doing with a male, I like to come down vertical. Kent, I'll give you to give me a hand over here. I usually take one of these little guys, and we just hold some pressure in the middle over here. Maybe, yeah, I don't know if we're going to be able to see very well.
See, she can hold it there from her side.
Yeah, better hold it from her side.
Right,
hold this.
in the middle. Okay, good.
Okay, you can hold it from below. Give me your fingers there. There we go. Okay, you can see that? You're going to feel a small little stick. I'm off the midline. 3, 2, 1, pop. I'm off the midline. I'm using Resty Lift over here. I'm injecting slowly. Sorry, that was a little bit of touching of the periosteum. The needle just sort of slipped a little bit. I'm going to keep, you can let go of it now. I'll keep this over here. Turn your head a bit so we can see with the camera. And I'm going to inject slowly, and I'm creating a bolus over here. keeping the product limited between my fingers. I'm using Resti-Lift. I would use Ultra Plus. I would use something that has, you were asking about Ultra Plus before. This is a great place to use it. Resti-Lift is also a great place to use it. I'm using it pure, so I'm going to need a little bit of a pad because the lidocaine will make him bleed just a tad. Okay? All right? I've already created one of his little buttock bumps over here. Okay? And we're going to do the same thing on the other side. There's why, see the difference with a little bit of epi and no epinephrine in the product? It makes all that difference. You want to hold that? I'll come around to the other side so that we don't obscure the vision.
I use straight up products here too. I don't blend for this at all.
You need all the strength of the product that it can muster, and if you want to use Radi-S, this is a great place to use it. I'm okay. You can do it. Thank you very much. So you want to come back in and focus over here, guys, for a second? Beautiful. Let me see which way. Everything's backwards on the camera when you look at the monitor, so you got to make sure that we're doing this. I'll try to do this without an assistant. I'll hold this small little stick. Bingo. There we go.
I got it.
Got it?
Yeah.
Beautiful. So I get them to hold a pencil or something over here when I'm doing this. I'm just trying to create two little bumps. I don't want to create a huge cleft on him. He didn't have a big one to begin with. And anytime I do anything midline or any type of anterior projection of a cheek, I'm always looking at the patient from the top of the table to make sure that there's symmetry. Symmetry isn't only left-right. Symmetry is also an anterior projection. If he's sitting down having supper at a dinner or at some restaurant, thank you. There he goes. He's got a little butt chin. See that? It's cute. So I check them. It's hard with this table, but I check them. Lift your chin up just a bit to make sure. You can see that little cleft that we maintained over here.
That cleft, as most of you know, is a dominant trait.
That's better. I like that a lot, actually. So I check it from above to make sure that he has the same amount of projection from both. In his situation, he would actually list a little bit to the left, maybe, because he has a little more product here on the left. Mm-hmm. So I'll take a teeny bit more product, and it can be... There's a small amount left. That's what we left here.
You need.
So I'll show you the other technique that you can do is lifting the chin up and just letting the chin fall back down onto the needle. I'm in a more subcutaneous plane over here, and I'm going to put in just a little teeny bit over here. Okay?
Is that 1 cc?
I used 1 cc for his chin, half and half. Because he had a fair amount of retrusion of his chin. Can you stick out your lower lip for me like this? Beautiful. And and those, I always combine it with
Botox.
Yeah, with a little bit of neuromodulator. Because that'll make the product last even longer and it will smooth out that area. But
so
that's a nice
show
looking
where you would use neuromodulator.
Come on, that's a nice looking chin on a guy. Okay?
You show them where you would use neuromodulator on his chin.
When I do the neuromodulator on the chin, there's a number of different ways to do it. The chin muscle, the mentalis, is a corrugator, the same thing as your corrugator up over here. It goes from bone to skin. Here it's going from bone to skin. It's doing the same thing, but it looks like a broccoli. It's coming from deep, being attached to the bone just below the mental crease, and as it comes up, it does this. If you cut across the chin on an anatomical dissection, you'll see little bundles and fascicles of stuff. So what I do with my chins, I'm a little more aggressive with them now than I used to be, is I usually put in one injection that's deep over here to catch the belly of the muscle, and the rest has got to be subdermal, because that's where all those little fascicles are. Stick out your lip, please. And I do them right where you see these rugae over here. So I have a 3 little point injection that I do, sometimes a little more, and I typically use 6 to 8 of Botox. Maybe that would be the equivalent of 20 of Dysport, 6 to 8 of Xeomin. You?
Yeah, I use it a little bit less, but that's exactly the same location I do. And then the DAO.
Yeah. Yeah, the mental crease, in order to get rid of the mental crease, I told you, lower face for me is my struggle. Lower face for me is my challenge because it's a question of volume. It's a question of support. It's those 2 drunk guys, and this guy is trying to hold this guy up. And it's also a question of movement and dynamic and proportion. So everything is moving. It's the lips in relation to the chin, to the nose, to the jawline. Everything is in relation to itself. So that's where I struggle the most. And very typically, and I learned this from Kent, is my treatment is in layers over here. I find that I'm usually doing deeper injections to give a little bit of volume or structure underneath, and then I'm very commonly coating over underneath the skin to give it more support, like a trellis. So it's usually a layered thing, and it's also a project. As he mentioned, I bring the patients back and I even chase the lines in the skin afterwards. So it's really a more difficult area for me to sort of address. But I do. I mean, we do that. And I tell patients that it's going to be, they have to be a little more patient with me with the lower part. But to get this thing out here...
He's got a little bit of a crease. Some of them where you can plant potatoes in there. Then
can I have a wet and dry
you'll use a subcision technique with a 25 gauge cannula, break it up, and then do it again in 3 or 4 months when they need their Botox. And if you do that a few times, you can make it probably 50% better. But it's kind of no man's land. It's tough, even with a laser.
Perfect. Clench your teeth. Good. You can, and what you'll do is lengthen the chin slightly. You'll also prevent, what you do is, by the way, don't let them leave the office looking like that.
Yeah.
And not because you'll be chastised for it, but because every 16-year-old kid in the city is going to want one the next day. Okay? When I do mental creases, they're done in layers. That's what I meant to say. Yeah. And it's very commonly, I'm putting in quite a stiff product just subdermally to give it a little support. Then I have to do an intradermal injection. The tendency will be to support the lower lip. For people who have a tendency to have their lip drop down, you'll support them and you'll elongate a little bit of the chin. So be careful with that as well. If you want to do that, you can. But whether or not it should be treated, as far as some people come in and they say, it's something that bothers me. Or if it's really, really prominent, like on a witch's chin, as we call it, the witch chin, then I would treat it, yes. And I'd always add in toxin. Always, always, always.
All right, we're going to go into break now. The doctors still will be up there, so if any of your questions weren't answered, feel free to go up and ask away. But otherwise, if you could all come back in 10 minutes.